Hello, my name is Kate Chesterman. I'm a salaried GP in South Norfolk, and I also co-host the GPnotebook study groups. Welcome to the GPnotebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. You can find us on all major podcast platforms, including Spotify and Apple and Google podcasts. Please follow us to receive notifications about new episodes, and if you like what you hear, please consider leaving a review to help other listeners find us. Finally, you can visit GPnotebook.com for podcast episode show notes and to find out more about upcoming study group meetings. During this podcast, I'm going to be discussing post-herpetic neuralgia, focusing on the management of this painful and distressing condition. So let's start by considering how post-herpetic neuralgia might present in primary care. Mr. Williams, a 72-year-old type 2 diabetic, was seen by yourself 4 months ago with a 2-day history of a painful rash over his right scapula and a feeling of general malaise. When you examined him, you noted an erythematous maculopapular rash in the distribution of the right T1 dermatome, and you correctly diagnosed shingles. You prescribed a 7-day course of acyclovir, and the rash cleared over the next 3 to 4 weeks. But Mr. Williams has come back to see you, concerned that he has ongoing pain in the area affected by the shingles that does not appear to be settling. He describes the pain as an itchy, burning type of pain, and he also mentions that the skin feels very sensitive. Examining him again, you note mild scarring in the distribution of the original rash, and your light touch seemed to result in significant discomfort. You diagnose him as having post-herpetic neuralgia, which you explain is pain persisting for 3 or more months after the onset or healing of a shingles rash. The rash occurs in the same distribution as the shingles episode and is caused by herpes zoster-induced neuronal damage, secondary to an inflammatory response to viral replication within the affected nerve. Post-herpetic neuralgia is the most common complication following an episode of shingles and can affect up to 1 in 5 people, with 80% of cases occurring in patients over the age of 50. The pain is typically described as burning or electric shock-like and is often associated with allodynia, where the pain is precipitated by a non-painful stimulus, such as light touch or the pressure from clothing, and hyperalgesia, which is an abnormally heightened sensitivity to pain. Post-herpetic neuralgia is an important condition, and its effects on both physical and psychological well-being and quality of life are well documented. Sleep disturbance and depression are not uncommon, and these effects need to be explored and addressed when we are supporting patients with this condition. The development of post-herpetic neuralgia is more common in older age, and the association between increasing age and incidence of post-herpetic neuralgia is significant. Around 60% of patients with shingles develop post-herpetic neuralgia at age 60, and this increases to 75% by age 70, according to some studies. Post-herpetic neuralgia is also more common in those who had a severe prodrome, rash, or acute shingles pain, as well as those who are immunosuppressed, have diabetes, or ophthalmic involvement. There is some evidence that prompt treatment with antiviral therapies during acute shingles episode can prevent the development of post-herpetic neuralgia and reduce the severity of the symptoms if it does occur. The optimum time frame appears to be within 72 hours of the onset of the rash, but some studies have suggested that treatment up to a week after the rash starts, particularly in those with risk factors for severe disease or post-herpetic neuralgia, may be of benefit. Post-herpetic neuralgia is notoriously difficult to treat, with a significant number of patients achieving only a modest reduction in their symptoms despite combinations of analgesic agents. And we need to remember that these patients are often elderly and frail, and may already have polypharmacy or multimorbidity that limits the use of stronger analgesics or neuropathic agents, and these factors need to be considered when prescribing. Self-care advice can include wearing loose cotton or silk clothing to avoid irritation of the skin. A protective layer of bandaging under the clothes can also be helpful, and the regular application of a cool compress or cool shower can also help to alleviate the pain. Unfortunately, there is little evidence that simple analgesics, such as paracetamol or anti-inflammatory medications, result in any meaningful improvement in symptoms. And for many patients, pain control will involve the use of tricyclic antidepressants and/or anticonvulsants. The choice of which to use first line will depend on your patient's age and frailty, comorbidities, and the potential side effects associated with the different medications. Tricyclics, such as amitriptyline and nortriptyline, have proven efficacy in reducing the pain associated with post-herpetic neuralgia, although they do not have a specific license for treating this condition. Interestingly, some studies have concluded that nortriptyline may be better tolerated in elderly patients, which means that it is often used as the first-line choice. A low dose, such as 10 milligrams, is usually recommended initially, and this can be titrated slowly, probably in weekly increments, depending on the patient's ongoing symptoms and any side effects. Although an improvement is often seen within a few days of initiation, maximal benefit might not be seen for several weeks, so it is worth persevering for 4 to 6 weeks unless the patient has unacceptable side effects. If it has worked, then it should be continued for a further month before being slowly reduced. It can be restarted or up-titrated if the pain returns. Possible side effects such as confusion, sedation, and urinary retention may limit the use of tricyclic antidepressants or make them inappropriate in some patients. Anticonvulsants, such as gabapentin and pregabalin, have also been shown to reduce pain and improve sleep in patients with post-herpetic neuralgia, and are often considered when tricyclics are ineffective, not tolerated, or contraindicated. Again, it is recommended to start with a low dose, such as 300 milligrams of gabapentin once daily, or even 100 milligrams daily in the elderly population, or 75 milligrams of pregabalin twice daily, and then titrate slowly to achieve control of symptoms. Again, side effects such as sedation, ataxia, and weight gain may limit the use of these medications in some patients. Duloxetine is another option that can be considered and has been shown to be beneficial in helping to reduce neuropathic pain and may also help to improve any associated psychological distress and depression associated with having a long-term pain condition. Strong opioids have also been shown to reduce pain in patients with this condition, but the risk of side effects and addiction need to be considered when prescribing, particularly when considering that any medication for post-herpetic neuralgia may need to be prescribed for a prolonged length of time. Opioids are usually recommended for acute rescue therapy rather than long-term use. If itch is a predominant feature, then the addition of an antihistamine may offer some relief. 2 topical treatments are also available. 5% lidocaine plasters can be applied to the affected area in a 12 hours on, 12 hours off regime. They are particularly helpful if allodynia is a prominent feature, or if patients are unable to tolerate systemic treatments. They are usually well tolerated and so are often used, despite the limited evidence for their effectiveness. Capsaicin 0.075% cream is also licensed for the treatment of post-herpetic neuralgia once the lesions have healed. It should be applied 4 times a day, and it can take 4 weeks for a benefit to be noted. Some patients do report a burning sensation on applying the cream, but this tends to diminish with continued use. It is worth being aware that a multimodal approach with combinations of the therapies that I have described may be needed to achieve tolerable pain levels. The involvement of chronic pain clinics can be helpful to those with refractory symptoms or those with severe pain that is significantly interfering with their daily activities. Other options available at these clinics may include a stronger 8% capsaicin patch, nerve blocks, spinal cord stimulation, epidural injections, Botox injections, and psychological interventions. Increasingly, due to the well-documented long-term effects of shingles and post-herpetic neuralgia, the management of these conditions has focused on prevention, and this is a fundamental consideration when approaching this condition. We know that the prognosis is variable. Some patients may have a complete resolution of their symptoms, but this may take several years. Other patients may need to continue analgesia indefinitely and can be refractory to treatment. The addition of the shingles vaccine has been extremely promising, with studies showing significant reductions in the incidence of both shingles and post-herpetic neuralgia, and it is therefore worth encouraging the uptake of this vaccine in those who are eligible. So thank you all for listening. I hope you found this podcast helpful. Please do have a look at the show notes that accompany this episode at GPnotebook.com, and would be very grateful if you would consider following the podcast and leaving us a review on your favourite podcast platform. Feel free to get in touch via social media at GPnotebook or email support@gpnotebook.com if you have any questions, comments, or ideas for future episodes. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups and download free shortcuts which are designed to help make your lives a little easier and ultimately help improve the lives of our patients in primary care.